welcome to the Markey Cancer Center Affiliate Network's COVID-19 and Cancer web series. As Jerome mentioned, I'm Sherry Toll. I'm the Administrative Director for the Markey Affiliate Network. We're glad you joined us today. Most of our programming is usually developed and offered exclusively for our McCann members. However, due to the emergent nature of COVID-19, we've opened the web series to those outside of the network. So if you're new to our McCann educational programming, we're glad that you're here. Today's webcast is the role of palliative care in the COVID-19 pandemic. As COVID-19 has dramatically altered our world and healthcare systems, it has stressed the capacity of our hospital infrastructure, our hospital personnel, and our relationships with patients, especially those at high risk. And palliative care focuses on quality of life, discernment of patient goals, advanced care planning, pain and symptom management, and support for caregivers. So in this time of COVID-19, palliative care has never been more important. So to help us understand the role of palliative care in the COVID-19 pandemic, we're delighted to have Debra Gleason as our speaker today. Debra is an advanced practice nurse with the Interstitial Lung Disease Clinic at UK Healthcare, and she served previously as the transitional care leader for palliative care at UK. She will discuss how those at highest risk for COVID-19 are palliative care's core population, and why those unique skills and strengths found in palliative care must be part of our response. Welcome, Debra. Thank you for sharing your time and expertise with us, and I will turn it over to you.
You're welcome. Good afternoon, everyone. It is great to have a chance to be able to talk about palliative care today, something that I'm extremely passionate about. So I'm happy to share my knowledge with you, and hopefully you'll gain some skills out of this presentation. Facility, outpatient, inpatient, even long-term care really needs to learn about, so that to get us through this pandemic, and then also take those skills and add them to your education and your practice every day. So just a brief introduction. I'm hoping that everybody on the call knows what palliative care is, but for some of you who don't really know what the definition of is and think about it as hospice, just a quick definition that we are a medical specialty that deals with people with serious or chronic illnesses anywhere from the time of diagnosis throughout the course of treatment. And it really optimizes the quality of life by anticipating and preventing and managing that suffering. We have an interdisciplinary team. We are physicians, nurses, nurse practitioners, social workers, chaplains, pharmacists, and we really use that team to try to provide the best quality of life for our patients in various areas. As it said, it can occur at any time in the disease process, which is really important. Somebody asked me the other day, when should I call palliative care for support? And I always say at the time of diagnosis. It's not hospice, so you can have curative treatment, you can have your plan, and we really hope that you get better. But palliative care might be a supportive service that can help you get through that troubled time. And it is not hospice. And we try to make that distinction in terms of all palliative care can be hospice focused, but not all hospice is palliative care focused. So right now, if you look at the CDC or the World Health Organization, they have identified really high risk factors for these patients in COVID-19 times. And as we would assume, it's those with those chronic serious illnesses, diabetes, heart conditions, lung conditions, even people with severe obesity, those that are immunocompromised. So our cancer patients that may have been or going through treatment, the liver disease patients, people that are 65 and older. And I'll show you a slide that has some statistics on some of these chronic illnesses and how that has affected the mortality rate. So as you can see, those are all palliative care patients. Those are patients that we see every day in our clinics, in our hospitals, that we can help, because these are all chronic serious illnesses that need patients to identify and then also seek that supportive care that might help them get through these serious illnesses that may last years. So here's a slide that talks about, and this came from the World Health Organization, about fatality by the rate of comorbidity. And this is not to say that these patients represent the share of deaths by pre-existing condition, but this is rather the statistics that show the risk of dying with these chronic illnesses. So as you can see, cardiovascular disease, we know now, is probably the #1 identified risk factor for these COVID-19 mortalities. And so diabetes. And then what was surprising to me when I first started learning about COVID-19 was, certainly I would have thought, since we're talking about a respiratory virus, that our chronic disease patients would be at the top of the list. And we're actually seeing now, as we learn more and more about this virus, that the cardiovascular component of this virus is complicated and really puts a toll on those patients that have cardiovascular disease, hypertension, and then cancer. So what are the palliative care skills related to COVID-19? And they've changed a little bit because obviously our situation has changed, our resources have changed, and sometimes our focus needs to be a little bit altered because of the availability of families to have discussions. So I've broken it down into 4 areas. And the first one is goals. So we always deal with patients sometimes that have an acute episode that what might be collapses the house of cards, as I say. So it might be the straw in the camel's back, that's just that one more thing that a patient with serious or life-limiting illnesses might change their view about what their goals of care are. So in COVID-19, the palliative care teams can do a real quick assessment of the patient and help them look at what their goals are and align those treatment plans. Those are really our strong skills in palliative care. We're able to go in there and kind of identify those, and they have changed. It may be an individual who wanted to have all the treatment in the world. I want to do everything, they say. But then we look at COVID-19 and how it affects their chronic disease and what it might look like even if they get over the COVID-19. What does life look like, or functioning look like, after the disease process? So we're really good at coordinating. I think probably one of the things that we do best is help gathering team members together and kind of having those discussions, helping patients talk to their family members, understanding what kinds of options there are. So we're really good at pulling everybody together. And I think in a big academic center like UK, where there's so many specialists and so many team members and people rotate in and out of patients' rooms, the team at UK actually has the opportunity to be able to be somewhat of a constant in that turmoil, and that they may see the same person from that department over and over again, or maybe one or two. And then they're involved with the social worker and the chaplain and the pharmacist, and really having that team that is basically the same people over and over, that they can develop a relationship with, that they can have conversations with, and that the team can help coordinate that care, having the primary care team come in and talk to the patient, many family meetings, pulling in specialists. So that's really one of our big skills, as I say, in palliative care wheelhouse, and even more important in COVID-19 because everybody's so spread out. Support is definitely something that palliative care does all the time. And sometimes it's our other members of our interdisciplinary team besides our medical providers. So our chaplains, our social workers, our pharmacists that are able to provide that additional support to these patients who are going through all kinds of frustrations, certainly moral distress and grief, and also to staff members. So there's been many situations in my experience where we have not necessarily been there for the patient and the family. They may be doing okay, or they may think they'd be doing okay. It's the staff that we really provide the support to. I'm sure you've heard a lot of talk and maybe read some information about moral distress. So that may be something that palliative care can help with the staff. We always talk to nurses who are so torn between decisions that patients make and decisions that they think the patient should make. So sometimes palliative care is there to help the staff more than the patient. All right. So in this time of COVID-19, we really want to be careful in our communication on what matters to patients. And we're in a situation right now where we're being told what to do. Wash your hands, wear a mask, stock your kitchen, all those kinds of things. Stay inside, don't do this, don't do that. And so part of what we need to do here is really think about what kind of control we can give to patients and families in this situation where they don't have much control. So we really have to understand when we ask people to make these decisions, are we creating anxiety in putting pressure on people to make those decisions? That can ultimately harm people and even provide more control that they try to fight against. So we're going to talk a little bit about how we can use certain words and not use certain words to be able to give control to these patients as much as possible. So recently in a study done by the Cambia Health Foundation, they did a research project that looked at how we talk to patients about advanced care planning, about goals of care, all kinds of treatment options, and having those conversations. And they really wanted to know what people thought about some of the language that we in palliative care use all the time, that people, physicians, providers ask patients and families, what kinds of attitudes or beliefs do you believe when we say these kinds of things? And so first they looked at the goals and values and kind of what their attitudes were. So they found out that some people who were single or didn't have family members often were alienated by the term loved ones. You know, they may not have a family, they may not have, they may be single, they may not have a loved one. And so they saw that that was a troublesome term that people felt uncomfortable with when we were talking about goals of care. The others were put off by the idea that advanced care planning is a gift and it can ease the burdens of those who must make decisions for someone else's care. So they felt uncomfortable. I don't want to give a gift. You know, the idea of a gift and easing burdens was something that triggered people that felt like they didn't have control in the situation. And in terms of advanced care planning, some people had done advanced care planning from a situation where it was done in confidence. They had an idea of what they wanted. It was pre-planned. I saw a patient the other day, 72-year-old woman who with pulmonary fibrosis, who has a rapidly deteriorating situation, and she had already planned her advance directives, already had a living will, knew what she wanted about DNR. And so she certainly wanted to ensure that the quality of life that she had was really the driving factor for what kinds of future decisions we wanted to make in her treatment plan. What they also found out is that some of those people who have disabilities, economic status, those kinds of things, that it came from a place of quick decisions, and that it usually was based on seeing a family member's decision go poorly, or they commented that Aunt Susie had a trauma and was put on a breathing machine, and I never want to be like that. I don't want to have my family, take me off the breathing machine. And so it was made more on quantity than actual quality. So it's not a surprise that the final result of their research project was that people really wanted control. And especially in times of COVID-19, like I said, where we're being told to do all these kinds of things. So it wasn't full control, but it was kind of a conditional, limited control, like how we would choose somebody to make decisions about our healthcare. And so this is the kind of control that we can offer these patients right now. And we really should when we're working with advanced care planning with goals of care, treatment options. So our control issues certainly go well beyond letting our patients to, and I'm sure if you have had any time at home, that our control issues about not eating too many Oreos or not eating just one Lay's potato chip can certainly resonate about control issues. So how do we have these conversations with people in the light of COVID-19? And we have to kind of tweak what we say to patients in terms of their healthcare decisions, because we're talking about a virus that we still are unsure about. We're learning every day about it, but we can give them information about how it's going to affect them with their chronic disease. So this is a great resource, and at the end of my presentation, I have some websites that will be great for you to access to get these resources. Goes through a conversation guide, and this happens to be an outpatient version. You could use it in the inpatient version too. And so I use this with my patients, and I even take it into the room with me, because I want to make sure that I touch all the topics. And if you can see kind of on the left-hand side of the page, it kind of breaks it down into the conversation. So first we have the setup, and it goes through things. But I take it in because I tell the patient that I have this guide in front of me. It's important for me to remember that I ask all the questions to you to find out what's most important to you. And people are really understanding about the fact. They don't think that you don't know what you're doing or that you don't know your job. But just reinforcing that, hey, I'm using this guide because there are some things that we want to talk about that are really important. And I want to make sure that I touch on all the topics so that we can have a good conversation. So setting up the conversation at the beginning, good introductory sentence. This is difficult and scary time with the coronavirus. I'm hoping that we can talk about what's important to you so that we can provide you with the best care. Is that okay? Always asking the patient if it's a good time to ask for having the conversation. It may not be if you're in the inpatient setting and the patient is having a procedure or just came back from something and is really tired. If it's in an outpatient care setting and the patient is just there to do their blood tests, and so they don't want to do it right then. They'd rather choose a different time. And so next you're going to assess kind of what they understand. Now in regular times or normal times without COVID-19, we're going to ask them what they understand about their disease process. So what do you understand about your cancer? What do you understand about the treatment that you're going through? What do you understand about your heart disease? And get a good baseline as to what these patients understand about what they've been told. Because I know almost every healthcare provider can think of a situation where you have talked to a patient and either they were misinformed or they were not informed. And so this gives you an opportunity to be able to have that conversation about, this is what I know about your disease process, and kind of share that with them. Then you want to share things with them to give them some more information. Most people who get the coronavirus get better on their own. However, people who are older and have other health problems like yours can get very sick, and they may not survive. So the treatments that we use to help people live, like breathing machines, may not work. If they do, the recovery from the illness is uncertain. And certainly this is a great sharing statement that we use every day in palliative care. We've just tweaked it a little bit to let them know that, hey, we might be in a different place because not only are we dealing with your chronic illness, but now we have this other virus that we know is going to affect the outcome of your chronic illnesses a little bit different. So then we're going to go and we're going to explore, and we're going to explore their goals, their thoughts, kind of what they've thought about so far since we're having this conversation. So with all that's going on, what are you most worried about? And sometimes people have a little bit difficult time with this question. And so you can expound on that. One of the statements on this guide is, what abilities are so important to you that you can't imagine living without them? And that really varies. I know in palliative care, we can tell stories about patients who, living in a hospital bed, being able to talk to their family members, blink their eyes, see their grandchildren, is what is important to them. And other people are like, you know, if I can't go out and work in my garden, or if I can't walk around the block or take care of my animals, then life is not important. The quality of that life is not important to me. So really getting an idea of what's important to them, but asking them about the abilities, asking them about their functional status. What is most important to you? Is it okay if you can't bathe and dress yourself? What if somebody had to feed you? So getting an idea of what those things that are most important to them are. And then also kinds of what kinds of medical treatments they would want and they wouldn't want. Would you want CPR? Would you want a ventilator? And then finally, just closing with acknowledging the fact that this conversation has been really hard. And that at the same time, we need to talk about these things because it helps us as healthcare providers ensure what matters to you most. And that in this time of uncertainty, we'll help you make these decisions or help you share this information. But that it's really important that we think about it at this time. I always like to say somewhere in my conversation, either at the beginning or the end, is that I really hope that you get better. I really hope that you can play with your grandchildren again, or I really hope that you can go to that wedding. But if you can't, I want to plan for what will happen if that doesn't. I want to hope for the best, but let's plan for the worst, because it's much easier to plan ahead of time than try to make those decisions in crisis. So that's why I said identifying palliative care patients at time of diagnosis is really important, because we can help plan those things and talk to the patients about what their options are over time. Of a patient or a family member can use this tool to help them have conversations with their family. The Conversation Project is a wonderful resource for anybody. It's healthcare provider focused, and then it's also consumer focused. So it provides both resources. I know when I was in the inpatient palliative care department, we used the booklet, The Conversation Project, talking about here, this is just a conversation starter. These are some of the questions that you can think about, and then maybe these are some of the things that you can talk to your family member about. It also talks about healthcare surrogate. There's another handout that they have on what it means to be a healthcare surrogate, because some people may be chosen by the individual, may not be a family member, may be a friend, next door neighbor. What does that mean? Does that mean that I'm going to be in charge of all their finances? And so it's a really good tool to kind of allow patients and families to say, hey, what is a healthcare surrogate and what would be my responsibilities? So this specific guide is certainly focused towards COVID-19. We have other guides that are just addressing advanced care planning. But this is a challenging time. And so there are many things out of control. So what can we do? What kind of control can we give you as a patient and family to be able to write down things and look at the decisions that we're making and communicate those to those people most important to you? So you want to first always pick a person to be your healthcare decision maker. And I would say that in conversations about advanced care planning and goals of care, that it's much more about the conversation of who you want to be your healthcare decision maker than actually getting a form completed. So if I can have a conversation with a patient and they can identify, yeah, I want my daughter, Donna, to be my healthcare surrogate and my backup might be my son, that's really the first major step in getting them to do really good advanced care planning. I don't need to have them sign an advance directive. I don't need to fill out a most form. I don't need to complete a living will or 5 wishes. If I can document that, hey, she said that she wants Donna and then her son to be her healthcare decision makers, that's an important thing. And if you're fortunate enough to have electronic medical records or some way to communicate that to other providers or other healthcare members, then that's great. I know that we're challenged right now to get our communication about advanced directives really out to the entire enterprise, inpatient and outpatient. But hopefully that will be changing, and hopefully we'll be able to do that so that that can be shared across disciplines and across sites for care. And then talk about what matters most to you. So you've decided on who you want to be your healthcare decision maker. Let's talk about what matters most to you and have that conversation with them. Because then again, this is the second step in, hey, it's not necessarily about filling out a piece of paper, but it's about talking to your family about what matters. Talk to your healthcare team about what matters. Talk to your doctor when you go in and have your routine checkup. Talk to your specialist when you're in there for your follow-up appointments and let them know, hey, I've talked to my family and this is kind of what we've decided. So not necessarily the piece of paper, but just having that conversation. And like I said, we use in palliative care the conversation starter kit, which is basically kind of a little handout that helps people think about how they can talk to their family, because it's really difficult. And when you're talking to patients, you need to acknowledge that. You need to say, I know this is a really difficult topic, but I think that it's important that you discuss it with your family so that they know what you want for your treatment options. And then think about what you would want if you became really ill with COVID. So here we've kind of extended it past the chronic illness and into COVID. People who are older have chronic medical conditions and are more likely to become sick, as we talked about. And some will recover and some won't. And some will need a ventilator and some won't. So think about what would happen if you became really sick with this virus. What would you want? Again, revisiting what would be most important to you. What are you most worried about? I'm worried about being a burden. What is helping you through this difficult time? What are your supports? Trying to get an idea of what their coping mechanisms are. If you became really sick with COVID-19, where would you want to live? Where would you want to stay? Would you want to go to the hospital? Wouldn't want to go to the hospital? And then if you choose to go to the hospital, would you want to receive intensive care in the hospital or not? One thing that I am thinking about in terms of ICUs, I know that some of my colleagues on the East Coast and back in Colorado were really faced with having to have conversations because of a lack of resources. I think we were fortunate in Kentucky to not have the seriousness of the COVID-19, although it could come, as we know, but that there were several places across the country that really had to think about what resources they had. They were really faced with having these discussions and the situation and struggling with being able to not offer those resources, because I think here in the United States, we have the great opportunity that we have many choices for treatment for acute and chronic conditions. And so when we have to talk about withholding treatment, even though we have access to it, it certainly can cause a lot of moral distress. So thinking about, hey, I have this however 80-year-old patient who has a history of a chronic illness, may have had a cancer with treatment in the past, but you know what, I can't offer them an ICU bed. How you have those conversations, I'm fortunate that I have not had to have those conversations, but I do know palliative care colleagues that have had to have those conversations. And I would say that probably 100% of them will tell you that it's probably the most difficult part of their palliative care practice, because we have things but we can't offer to those patients. So what if we have patients who come to the hospital that contract COVID-19, that have chronic illnesses, that don't want to go to the ICU? Maybe they've made that choice. I don't want a ventilator. I don't want to be in the ICU. So having those conversations with a patient, and then maybe being the coordinator, as I mentioned, with the family, because maybe the family wants the patient to go to the ICU or have the treatment. So a lot of conflict there, a lot of things to think about. Very overwhelming in this situation with COVID. So you're probably asking yourself, I've explained a lot of things that we can do and provide palliative care for these patients, especially in time of COVID-19. How do I learn this role? So first, if you are fortunate enough to have a palliative care team, you want to access them. Are you in a facility that, an inpatient facility that may have a palliative care team? Do you know a local hospice or palliative care agency that can provide support? These days, a lot of agencies are expanding so that they have palliative care and hospice services in the community. And while this has been challenging for them lately to provide care in the home, they still are that extra layer of support that at least people can access by phone. You know, my patients I've referred to recently with their chronic illnesses to outpatient palliative care so that they can have an extra set of eyes on this patient, because it's not always easy to come into the outpatient clinic or to get a hold of somebody at the outpatient clinic. And you don't want to come to the emergency room, but you're having symptoms and you don't know what to do. Palliative care in the community is always great for that. So if you have access to an inpatient team, or I would highly recommend reaching out to your local hospice or palliative care agency if you haven't buddied up with them already, and really see what kind of services they can offer to patients now in COVID-19, and then also in the future for any palliative care needs. And then of course you can develop your own palliative care skills. There unfortunately will not be enough palliative care providers in this country to serve all the needs of the patients who require palliative care services. So I think one of our main functions in the palliative care world is to provide education to people so that we can teach basic, what we call primary palliative care, so that everybody can practice palliative care and be that first line of having those discussions and providing that support. So the skills that you can help yourself develop would be things about communication, some of the things that I talked about in those guides. I'll give you some resources at the end that you can access. There's actually a couple of places that are offering free resources right now in this time where we really have a need for palliative care. Learn about advanced care planning. Do you know what documents are legal and what documents are not legal in the state of Kentucky? Are you well versed on what options people have for filling things out? Do you know what a MOST form is? I happen to be part of the Kentucky MOST Coalition, and we are always trying to provide education on what a MOST form is. And if you don't know what a MOST form is, it's a pink piece of paper, that is a medical order for scope of treatment. And pretty much every state in the country has one. Sometimes they're named POST, sometimes they're POST. It really varies. So they vary in terms of what is actually on the form from state to state. But the overarching purpose of the form is that somebody can put down in writing what they want for end-of-life treatment. And this is really a form that you're talking about somebody who is in end-of-life with their terminal or their serious illness. Not for somebody who may be 50 that's getting palliative care that may have a really good rate of recovery. We're talking about people who may be closer towards the end of life, because it does discuss things like CPR, talks about feeding tubes, talks about hydration, depending upon which state you're in. And those are really decisions that people want to make before they're unable to, but you could get documented, and it can go from facility to facility with patients. So not to say that you can't have those conversations with people earlier in the disease trajectory, but the form itself is really for people that are closer to end of life. And then learning about patient support, family support, and staff support. Social workers and chaplains are great resources for learning skills in how to support your patients. Do they have other resources that are available for your patients? So what I can say is that you really can take the opportunity to learn these things, even though they may seem overwhelming and scary, to have these conversations with people. But there are things out there to help you learn these skills. So here's a list of free resources, and I'll leave this up for a couple of minutes here, talking a little bit about each one of them. The California State University, the Institute for Palliative Care, is a great resource. It's more healthcare provider focused. And they actually are offering free online classes until June 30th. They have a program through CSU that you can get certificates in palliative care. But that's a whole educational kind of college level program. But they have free online classes for everything from communication to support to all kinds of things. So I was really happy to see that they were offering free online classes, because their list of palliative care classes is really extensive, and you can find something for everybody on there. Ariadne Labs is a group of professionals that was started by Atul Gawande. And he is focused on chronic illnesses, serious illnesses. It also has some other medical topics, but the thing that I would focus on if you go there to look at what they have to offer is their serious illness component. They had that first outline that I showed, the guide, the outpatient guide that I use with my patients is on that website. These are free. And so you can go there and download it and use it. They have more resources for talking about patients in COVID-19. And then they also have their whole serious illness project. So like I said, that guide that is COVID focused. Then also we have one where we're just with serious illness. So you can have both of those. And they have videos and, they offer webinars and those kinds of things. So that's a really good site to go to. Vital Talk, that's another great site. It's a professional site, just like the previous one. So it's much more focused towards healthcare professionals. They have great resources. They have a whole COVID-19 workbook with resources in it. So they offer, some questions. They have a really good resource on there where they talk about questions that family members or patients may be asking just in general. Why can't I come visit my loved one? How long is this going to take? Those kinds of things that aren't necessarily related to palliative care focus, but some things that people would ask you about healthcare in these days of COVID-19. They also have some great videos on there. I was actually watching one a little bit earlier today, which they just put up not too long ago, that was specifically a conversation, just like the guide that I said, but a conversation between a provider and a patient who had cancer. And she was getting chemotherapy, and she also was COVID positive. And so there's a great, I think it's about 3 or 4 minutes, a great dialogue between the provider and the patient in terms of, hey, you have this serious illness and now you have this COVID-19. So let's talk a little bit about it. It was a really great resource. So they have other non-COVID related videos on their site too. The End of Life Nursing Education Consortium, LNEC, some of you may be trained in LNEC. It's mostly focused towards nurses, but I've had social workers, chaplains, other healthcare professionals take the course. They have a great resource that's also free. That website will take you right to their COVID-19 page, and it provides communication guides, a lot of things on palliative care, some things on hospice. They're a great resource both for COVID and then also for communication, symptom management, those kinds of things that we provide as nurses for not necessarily just end of life, but for palliative care also. And then finally, the Conversation Project. That is both a consumer and healthcare provider website. And I referred to it a little earlier, the Conversation Project handout that we've used in palliative care, both the Conversation Starter Kit and the Healthcare Surrogate handout. Those you can, I believe you can download them or print them off. You can also order them specifically branded with your facility that you can hand out to patients. You can refer patients and families to that website because, like I said, that one happens to be consumer focused also. So they can go on there and look at all the things and learn more about advanced directives and palliative care and kind of what their options are. So those are really great free resources out there when you're talking about advanced directives. It's also great free resources, like I said, really learning, taking the time to maybe take a class on the CSU side on communication skills, how to have difficult conversations. So those are great resources that you can access. So I want to leave some time for questions. So I just want to close and say that in this time of palliative care, it's just as critical as ventilators and fluid and fever reducers and all those kinds of things. And what we know from the research is that palliative care is a positive outcome for patients and families. And so what I give to you is that your role now is to use palliative care skills to provide care that is patient-focused and goal-oriented. And certainly in this time of COVID-19, we need to keep the care in healthcare, even as systems and providers and patients are under siege. So here's my advice: stay home if you can, connect with people who matter in your life, reach out to offer support in your community, and know who will speak for you if you can't. And also keep a good supply of Lay's and Oreos in your closet. So with that, I will take some questions.
All right, I have some questions already.
All right.
All right. First question was about the documents and PowerPoints. Someone wanted to know if we were recording this and will have a PowerPoint that we can share. That's one question I can answer. Yes, if you're an affiliate member, we will have this on our resource portal. And if you're not an affiliate, you can shoot me an email at Jerone, jerone.farley@uky.edu. So that's one question I can answer. Here's questions for you, Ms. Debra Gleason. How does a patient and family request palliative care, and when should they request palliative care?
Good question. So the first answer is it's really going to depend on the facility that you're working at. If it's an outpatient setting, that's the time when I said you really should reach out to your agency, hospice agency, to see if they offer community palliative care or if they have an outpatient setting. So it's really going to vary. In the hospital, we've seen an increase in palliative care providers in the inpatient setting over the last 5 years tremendously. And so it's something that families can ask the doctors or nurses even at the hospital if palliative care is something that's provided in the hospital.
Okay. All right. Second question. Because of COVID-19, do you think that palliative care is more important, and have you seen an uptick in requests for palliative care?
So yes, I think that it's more important, and because we're having to have some difficult conversations in situations where we may not have had to have them now. So for example, with our cardiovascular patients, maybe they contracted COVID and they're in the hospital and their disease trajectory may have been slowly getting worse, but now we've added COVID-19. So we've added a whole different picture to it, and it's going to affect them a lot differently than it would somebody who doesn't have that comorbidity. So I think it definitely is more important now. We're having to have more conversations, quicker conversations, and that I think there has been. I know my colleagues outside of Kentucky in the areas that got hit the hardest on the East Coast and then also in Colorado have definitely seen the request increase.
Okay. Speaking of communication, because of COVID-19 and people's fears of going to the hospital, have you started using telehealth for palliative care?
Yeah, telehealth is huge. And in fact, I've been reading some articles lately on how those facilities or those agencies that have outpatient clinics for palliative care have seen an increase in their touches. So I know in our clinic we do a lot of telehealth, and it's definitely been on the table for topics of conversation, not just because somebody's in person Can you have those conversations? So we definitely, I'm hoping that this pandemic will increase the use of telehealth and the reimbursement. So I think that'd be great.
Okay. All right. So when do you ask, I think you cover this, but I'm going to ask it anyway. When do you know to ask patients what they want? Or does that depend on the patient?
So that's a really good question, because you need to get kind of, as I say, a read of the room or a read of the patient. And that opening statement that I mentioned in the guide, in talking about, hey, we're in this really difficult time and I'd like to have this conversation with you, is it okay, allows the patient the opportunity to say yes or no. So you can bring it up and say yes. They can say yes, and then you move forward with that conversation, or they could say no, and you don't have those conversations. I know that there's many times in our palliative care world that we'll walk into a situation where the patient just doesn't want to talk about it. And in that sense, you need to develop that rapport with them, that relationship with them, so that maybe you can ask that question down the line. The one thing that we worry about in palliative care is that we badger people too much about making those decisions. And I think maybe in this time of COVID-19, where people are so seriously ill, we don't want to badger with them. And that's the whole control issue, is still giving them control to make those decisions.
Okay. Here's looks like a general question about palliative care. How long can you be in palliative care?
Forever. You can really, because it's not, well, first of all, because it's not really paid for. There are some health insurance companies that pay for it. Sometimes community agencies pay for it under home health. It's really not, we don't work in palliative care to make money. So reimbursement wise, we don't have to worry about that. It's not like hospice, where there's a 6-month terminal illness requirement that a physician has to sign an order. So people could be in palliative care for years.
Okay. Now, speaking of hospice, this is the last question I have. When do you move from palliative care to hospice? And how do you know when to move from palliative care to hospice?
So hopefully you've had these discussions with patients about kind of what their goals of care are. And part of that conversation is saying what's most important to you. And when it gets to a certain point, then are we looking at more comfort-focused care than aggressive care? So if somebody says, you know what, if I can't get out of bed and walk to the bathroom, that's where I draw the line in the sand. Sometimes you have to say, what would tell you that it's time to go to hospice? Really give the control back to the patient and say, you know that this is what hospice is, because sometimes people have really strange ideas about what hospice is. What would it look like when you think that you would be ready to go to hospice? So get the information from them. The control issue is certainly the best way to try to get those conversations started with patients.
Great. So what it sounds like to me is that communication's a key point in palliative care.
That is our procedure. We call our communication our procedure. My colleague in the pulmonary clinic with me, his procedure is doing lung biopsies. So our procedure in palliative care is communication, and that's really what we're best at, and that's what we help teach other people to do. So that's really the primary focus.
Okay. Sherry, that's it with the questions from the audience. Do you have any?
Yeah, I've got a couple of observations and then maybe a question. I think when you talked about goals and coordination and support, that was really interesting to me, because helping patients with goals, we've heard about that with palliative care, and coordination with family we've heard, and certainly I think that's probably more important than ever now when family members can't be there, and a lot of that coordination has to be done either by the phone or through video conference. But the support for staff, that was new to me. And I really hadn't heard a discussion of palliative care in the sense of providing support for staff, particularly with moral distress. So I'm thinking that may be something new that our audience heard. It was certainly new for me, because I tend to think of palliative care as more patient and family focused and not necessarily staff focused. But I think certainly with COVID-19 especially, I could see where that would come into play. The other thing that I noticed in talking about making sure that we know for patients what's important and what's important to them is that can change. And it can change, particularly for people that have done advanced care planning. That, you know, if you did advanced care planning 20 years ago, you know, your perspective on what you may or may not tolerate or what you may or may not choose to do can change, and that it could change as the disease progresses for folks that are facing chronic disease, or just as time goes by. And I think also as different milestones emerge, that, you know, what you thought you might want 5 years from now might be different, or what you wanted 5 years ago, those things might be different now because there are new milestones or new things in your life. Can you just talk to us a little bit about that before we leave?
So yeah, I think advanced directives are fluid. We don't just make a decision and live with that forever. It may change. Families get estranged, you know, situations with your health. You may decide you're going through chemotherapy and you want absolutely everything, and that you get through 2 treatments of chemotherapy and you're like, oh, this is not what I expected to be. And I think that my goals have changed. So it's a fluid conversation that we as healthcare providers need to revisit on a regular basis, and it should never be a terminal discussion.
Yeah. And it goes back to what you said, that your primary tool in your toolkit is communication.
Mm-hmm.
Great. Well, Deborah, thank you very much.
You're
This
welcome.
has been a wonderful conversation. Thank you so much for the resources that you provided. And Jerome, I'll have you close up everything with reminding people how to get access.
Okay, so if you're an affiliate member and you want access to the video I'm currently recording, the PowerPoint, or the documents with the resources attached, please send me an email, and that is Jerome, once again with an N, .farley@uky.edu. If you are not a member of the affiliate network, you can shoot me an email and I will gladly share that information with you. So thank you again, Sherry, for being a moderator. And thank you, Ms. Debra Gleason, for your presentation today in such critical times. Thank everyone again for attending, and be safe out there. Thank you.
Thanks.
Thank you.